Hello, my name is Michael Zenn and I'm the Program Director of the Duke Plastic Surgery Residency. This video demonstrates the use of the ACGME Milestones in resident teaching. This video has been made possible by a generous grant from the Duke GME office. The Milestone Project is the end product of the realization that residents begin residency with only basic knowledge and skills and progress through various levels of competency until deemed competent to practice at residency's end. The Milestone Project uses levels 1 through 5, with the goal of attaining at least level 4 by graduation. Each specialty's RRC has determined which level of medical knowledge and patient care constitutes each milestone level. As a teacher, both faculty and resident teachers should understand the milestone level of the learner in front of them and teach to the next subsequent level. This graduated approach allows the prerequisite knowledge and skills to be in place for effective teaching to occur. We will demonstrate this concept with one of our plastic surgery residents, Kate, who is caring for patients with breast cancer.
Mrs. Jones is a 40-year-old female with a recently diagnosed breast cancer. She'll be having a mastectomy next week, and we've been asked to perform a reconstruction for her. She's a housewife, she has no other medical problems, takes no medications, and she's never had surgery. I examined her, and she has blood pressure of 120/70, pulse is 70, and she's afebrile. The breast exam revealed about a 2-centimeter mass in the upper inner quadrant of the right breast. I didn't feel any palpable lymph nodes in the axilla or the sternal area. I think she'd really appreciate having breast reconstruction at the same time as the mastectomy so that she wouldn't have to wake up without a breast.
Kate, that was a very nice presentation. She sounds like a lovely lady. Now, before we go and see her together, I want to ask you a couple of questions. Now, you didn't mention this, but is she going to need chemotherapy or radiation therapy for her treatment of her cancer?
I don't think so, but I'm not sure.
Now, I know you did a good focus breast exam, but did you examine any other areas of her body for possible reconstructive options?
No.
Is she a candidate for breast conservation?
I'm not sure.
Do you think it matters if she has lymph nodes that are positive for cancer, or if she's going to have radiation therapy as part of her treatment?
I know it's important, but I'm not really sure why.
Kate is currently at a milestone level 1. She understands breast anatomy and can perform a breast exam. In the operating room, she would be expected to be able to assist with procedures, but not much else. Appropriate teaching for Kate at this level would focus on the importance of lymph node evaluation and the determinants of adjuvant therapies like radiation and chemotherapy. One would also begin to explain the basics of reconstruction to allow her to begin discussing options with patients and obtaining informed consents.
This next patient has a history of breast cancer. She's a 45-year-old female who had a lumpectomy of her left breast for a 4-centimeter invasive ductal cancer. She has 2 lymph nodes positive and her deep margins also positive. The surgical oncologist now feels that she's ready for mastectomy, and they asked us to evaluate her for reconstructive options. She has no other medical problems. Other than her lumpectomy, she's had a C-section and a tubal ligation in the past. She takes no medications. She smokes 2 packs per day, small business owner, and has a 2-year-old at home. She also states that she's currently losing weight and she's lost 20 pounds, but that it's been intentional, and she actually wants to lose another 20 pounds. On exam, she is an obese 45-year-old with a BMI of 40, normotensive. Her breasts are a C-cup with grade 3 ptosis. On the left, she has a fresh scar at the 3 o'clock position and another scar in the axilla without any signs of healing problems. Her abdomen is obese with a well-healed suprapubic scar. She asked me about breast reconstruction, and I told her about using implants or her own tissues. And she really likes the idea of using her belly since she's always wanted a tummy tuck, and I think she's a good candidate.
That was a good presentation. She's an interesting patient, and there's a lot going on here. Is there anything in particular, do you think, that might increase her complication rate if we were to do breast reconstruction in her?
I was concerned about her smoking because I know that can increase her complication rate, but she said she'd stop for us before surgery. So other than that, I think she's good to go.
Given her positive lymph nodes her large tumor size, and the positive deep margin, it's likely she's going to need radiation therapy and chemotherapy. Kate has progressed to milestone level 2. Her history is more detailed and includes important information for decision making, but she has not fully grasped their importance. Her physical exam is more thorough, including pertinent donor sites. She is now comfortable discussing options with patients. In the operating room, she would be performing basic implant and nipple reconstructions and caring for patients who need surgical revisions. Teaching Kate at this level should take the basic knowledge she has gained and build on its significance. Explanation of how chemotherapy and radiation therapy impact healing and the durability of results will help her begin to formulate effective treatment plans for patients. Emphasis on tissue reconstruction is appropriate here. Her care of patients with complications on the floor and in the OR will help to crystallize these concepts.
Hi, Dr. Zenn. I saw a patient for you over in the Breast Cancer Center. She's a 50-year-old female. She's a patient of Dr. Smith's. She has a T3, N2, N0 invasive ductal breast cancer. She's completed neoadjuvant chemotherapy, and it was adriamycin-based. Dr. Smith's now planning to do a mastectomy plus a prophylactic mastectomy on the other side, and he said that she's also going to be receiving postoperative radiation therapy to the chest wall. She has no other significant medical problems, she takes no medications, and she stopped smoking 2 years ago. She has a stable weight, BMI is 28.5. On exam, she has B-cup breasts with grade 2 ptosis, no palpable tumor after chemotherapy, and I couldn't appreciate any palpable nose in her axilla either. She has adequate tissue in the abdomen for probably only one B-cup breast, but her back has enough skin for latissimus flap with an implant.
Kate, that was a beautiful presentation. Her stable weight and smoking status are really important to know about prior to making any decisions about breast reconstruction. Now, did you examine any other donor sites, like her buttock or her thighs, for possible reconstruction?
No, I didn't, sorry.
That's okay, we'll examine her together. Now, how do the recent adriamycin use and the need for radiation therapy impact our choices here and possible morbidities from our surgery?
My plan for this patient is to do immediate breast reconstruction. On the left side, I would propose to do a tram flap. On the right side, I would do immediate placement of tissue expander for implant-based reconstruction. So the first concern with using adriamycin would be, does she have any form of diastolic heart failure?
Kate is now at milestone level 3. She's capturing all the necessary history and physical examination details. She's using aspects of the history and physical to create a treatment plan, but still needs some assistance. She understands the immediate effects of radiation therapy, but not its long-term consequences. She seems comfortable with implant and pedicle flap options, but is not comfortable with more complex free tissue transfers from the thigh and buttock. In the operating room, she can operate independently and manage any complications with assistance. She independently corrects deformities created by surgery. Teaching at this level should emphasize some of the long-term consequences of adjuvant therapy and reconstructive procedures. Problem-solving of more complex cases should be encouraged. The resident should also understand the role of more complex free flaps and have a good grasp of the current literature surrounding them.
Hi, Dr. Zenn. So I saw a patient in my breast clinic today for breast reconstruction, and I was hoping that you'd staff the case with me. She's a lovely 35-year-old lawyer who had a previous left mastectomy radiation treatment. Her last treatment was actually 2 years ago. She's currently free of disease and ready to go ahead with reconstruction. She's at a stable weight, she's happy with her current C-cup size, and she's had no complications with her mastectomy and is currently only taking tamoxifen. I spoke with her surgical oncologist, who agrees that she's ready to move forward with reconstruction. On exam, she appears healthy, BMI of 29, normotensive. Her head and neck exam were normal. Examination of her chest reveals a well-healed mastectomy scar with no evidence of local recurrence. Her skin is hyperpigmented from the radiation, but it still appears soft to me. The right breast is a C-cup with grade 3 ptosis, and there were no masses palpated in that breast. She does have adequate abdominal pannus for a possible DIEP flap. However, her buttocks and thighs don't have adequate tissue for reconstruction. So I sat down with her and reviewed the risks and benefits of the implant versus tissue-based reconstructions. And while she could have a latissimus flap over an expander, she preferred to use her own tissues and avoid some of the complications that you can get with implants. These were complications that her and I had discussed together. So we spent some time talking about the DIEP procedure, including risks of flap loss, some of the potential abdominal complications, extended recovery time, and the potential need for revisions in the future. I even spoke with her about mastopexy on the other side to obtain good symmetry.
Kate is now at level 4 and considered competent in breast reconstruction. She has excellent understanding of breast cancer pathophysiology, adjuvant therapy, and reconstructive options. She can take this data and synthesize a reasonable treatment plan without assistance. She interacts well with patients and can effectively provide informed consent. In the operating room, she independently performs complex surgeries and can independently manage associated complications or deformities. She is ready to practice. Teaching at this level involves mainly mentorship by encouraging and facilitating leadership, teaching, patient safety, and quality initiatives. A Level 5 resident contributes to the body of knowledge on breast reconstruction by the creation of databases, IRB studies, and peer-reviewed articles. While not all graduating competent residents will attain Level 5, it should be the goal of all training programs. This concludes our demonstration of teaching using the ACGME Milestones. We hope this underscores the importance of evaluating learners for level of competency and then utilizing the milestones to direct future learning.